Hello, everybody, and welcome to today's webinar. Today's webinar is part of the monthly Healthy Longevity webinar series hosted by the Center for Excellence in Aging and Longevity, or SEAL, that is part of San Diego State University. My name is Jocelyn Protopappas, and I'm the Manager of Special Projects with San Diego State's SEAL. I'm thrilled to have all of you here today for an important conversation about food insecurity and aging. As we explore this topic, we'll dive into the challenges many older adults face in accessing nutritious food, how food insecurity can truly impact their health and well-being, and the current innovative solutions that are emerging in medical and community settings. The goal of today is to provide valuable insights that will empower you to make meaningful differences in your community. Before we get started today, I just wanted to say that we have a lot of people logging in from a lot of different places. So when we're talking about community, I just thought it would be really fun for everyone, if you're comfortable, to share where you're coming from and share your name so we can truly see all the different communities that are being touched by today's webinar. I also wanted to just mention a couple housekeeping pieces. This webinar is being recorded. It will be available in a couple days on the SEAL website if you'd like to review it or share it. Also, please feel free throughout the presentation to go ahead and share your comments in the chat or in the question and answer, and we will take all of your questions at the end of the presentation. If you experience any technical difficulties throughout the presentation, please feel free to directly message me, Jocelyn Protopappas, and I will do my best to help address those issues. All right, so let me introduce today's speakers. Kayla, if you can hit the next slide. All right, so guiding us through today's conversation, we are honored to have two incredible experts joining us from Providence, Milwaukee Community Teaching Kitchen in Portland, Oregon. First, we have Heidi Davis. She's the manager of Providence's Community Teaching Kitchen. She's been a driving force behind a hospital-based teaching kitchen model that integrates a food pharmacy, culinary medicine, and a prescription garden program. With a master's in social work from Portland State University, her research and work focuses on the intersection of social drivers of health, food insecurity, and equitable healthcare. With Heidi today, we have Kayla Guillory. She's a registered dietitian and a certified diabetes care and education specialist. Kayla's played a key role in advancing hands-on culinary medicine and food as medicine initiatives. She's passionate about promoting nutrition equity and addressing food insecurity, particularly with diabetes care. She earned her master's in clinical nutrition from Oregon Health and Science University and her undergraduate degree in dietetics from Cal Poly Pomona. Please join me in giving a warm welcome to my colleagues, my friends, and these awesome experts, Kayla and Heidi. Now, let's jump into the discussion. Kayla, I'm going to turn it over to you.
Awesome. Thank you so much, Jocelyn. Heidi and I are truly excited to be here with all of you guys today. It definitely is a really big honor to be able to share our program, the Community Teaching Kitchen, and just some of the work that we're doing here in Portland, Oregon. So the goal of this webinar is just to shine a little bit of light on how food insecurity impacts individuals, but more specifically older adults. So what we're going to do is we're going to explore what each one of us can do. So even if you're a medical provider, maybe you're working in the community, you're a student, caring for a loved one, maybe you're going through your own aging journey yourself. We're really hoping that you're going to be able to maybe take a few meaningful takeaways away with you guys today to share with your supportive circle. So let's go ahead and get started. I wanted to talk a little bit about what is food insecurity. So food insecurity means that we don't have reliable access to nutritious food to live a healthy and active life. And I think it's really important for us to understand that food insecurity kind of exists on a spectrum. And what I mean by that is, some folks it might look like they're skipping meals. For others, they might just be relying on low cost or inexpensive foods, maybe more ultra processed foods that might be less nourishing. Or it could just be that constant stress of wondering whether or not, you're going to have enough food by the end of the month or the end of the day or the end of the week, right? For older adults, for individuals in general, even short-term setbacks like a hospital stay, maybe we lose transportation or we can no longer drive, losing a spouse, a loved one, or now having to care for a loved one can really make accessing food feel just completely out of reach. So I wanted to share a little bit of a personal story with you guys. This is kind of what I'm going through right now in my own personal life. Is I think about my father-in-law. He recently moved up here with my mother-in-law from Texas, and they're finally here in the Pacific Northwest, but he hasn't been able to work because he's now caring for my mother-in-law full-time as she's living with dementia. And, he has had to take on a lot of responsibilities with just, learning how to cook, because this is something that, he didn't have to do in the past, learning how to grocery shop, how to cook on a budget, and also stretch his budget because now they only have one income. And it's really overwhelming, and it's been really overwhelming. And I kind of think about the work that I do every day, and it's just a really powerful reminder of how quickly things can shift even when you think that you're doing okay. And this is a reality that I think many folks quietly face. And without the right support or the right resources, food insecurity can really affect long-term or create long-term health challenges. So I last minute added this photo here on this slide. This is a picture of my patient's food pantry. He actually sent it to me 2 days ago through an email, and he was asking me, he was like, "Hey, Kayla, I need your help. I'm feeling really desperate and feeling really lost." He's a patient of mine that's been taking many classes with me, and we've been working together to manage diabetes. But this is all the food that he has left this month before he gets paid. I think it's either next week or the week after. And he was just feeling, desperate. Like, I just don't know what to do with all of this. And it's hard for me to keep on track. Like, can you help me? I didn't put the picture of his refrigerator. There's only maybe a couple condiments. He had some like ground beef in the freezer, but we were able to work together to put together a chili, something that he felt really good about, because it was really nourishing. It could stretch for multiple days until he gets paid next week. And yeah, he felt really good about this. And the reason why I wanted to bring this up is because this is a key concept of nutrition equity. So it's not just about having food, but it's about the support that you have, the food that's available. Do you have access to the right foods to make these choices? And this is where I'm going to dive into how nutrition equity plays a huge role in food insecurity. So what is nutrition equity? Nutrition equity means that we ensure that everybody, no matter their income, no matter their health or their background, can access foods needed to live a healthy and active life. But many of us know that systemic barriers such as racism, income inequality, and like lack of access to culturally relevant food make this really difficult for many, many folks. So I want you guys to take a moment and either, think about yourself or think about somebody that who might live in a food desert. So a food desert is going to be an environment where we don't have very many grocery stores nearby. Or maybe we live in a food swamp where all the food places or where we live is overly saturated with unhealthy options. Maybe food's close, right? But we don't have access to sidewalks. Maybe we don't have public transportation. Or maybe we are struggling with mobility limitations that really prevent us from getting to the places that we need to go. Okay. I think the point that I'm trying to get at is that where we live deeply impacts how and if we can access nourishing food. And it's interesting because every community is going to be different. You can live in one city and literally the city right over, doesn't have sidewalks, right? So it's not just about the food, it's not just about having food, but it's about, eating well, feeling well, aging well, and also aging with dignity. So I think this is where we can step in. We can help with education, we can advocate, but I think most important, we can support our community and the people that we work with and truly meet them where they're at. So example that I wanted to give you guys was back in 2020 when COVID rolled around. Many of our patients weren't able to make it here in clinic. And the reason being is because they were experiencing transportation challenges, but also we had to close our doors. We weren't able to have folks come into our clinic to see a dietitian. And folks didn't just come to our community teaching kitchen for nutrition education. They also come to access our family market, which is an on-site food pantry that we offer. And they would get a food box that they're able to take home. And this food would kind of help their food budget stretch for a few days. So what we were able to do was partner with Ride Connection, which is a medical transport company who serves older adults and also folks living with disabilities. And we would package food boxes and they would come by and pick up the food boxes and then deliver them directly to our patients, which was great. It was like we were able to still support them and provide them with nourishing food, but from a distance. It felt really good for all of us, especially during a time that, carried a lot of heaviness and a lot of uncertainty. So why exactly does this matter? Right? Why are we talking about this today? Why are you guys joining this presentation? And that's because food insecurity affects more than just our bellies, right? It impacts the whole entire person, especially when we think about older adults facing food insecurity. They tend to be at higher risk for things like malnutrition, depression, life-threatening falls, worsening chronic conditions, so things like diabetes, heart disease. Food insecurity is also very, very isolating. So think about, yourself when it's feeling really overwhelming to cook, or maybe you don't have the means to get to the grocery store. Meals can become pretty lonely, or maybe we start skipping them just altogether, right? So it's not just a nutrition issue, it's also like a health and quality of life issue. And if we're going to address this, we need to kind of focus on those better outcomes for our patients and our community members and the people that we're serving. Okay, so who is facing the greatest barriers? So I think it's important to note that not everyone who experiences food insecurity is going to experience food insecurity in the same way, right? So as many of us know, racial and ethnic disparities play a significant role. So Black, Hispanic, Indigenous, and immigrant elders often face higher rates of food insecurity. They also live in higher rates of poverty, possibly more in food communities, which tend to be food deserts. We also might experience language barriers, all of which are going to be making accessing nutritious foods even more challenging. So Heidi and I kind of see these disparities pretty often in the work that we do. And I think pulling back equity, this means that we need to recognize some of these differences and design solutions that are truly inclusive. So that could be, offering classes in multiple different languages, right? Or maybe we are celebrating culturally relevant foods. An example of this that we've done here at the kitchen is, in 2021, we received a health equity grant, and we partnered with a local nonprofit, Growing Gardens, and we took over the community garden that we have on site here at Providence Milwaukee Hospital. And what we were hoping to do and what we're working to do is really bridge the gap in diabetes care in our Spanish-speaking population. And so we've offered culinary and gardening classes, which have been really successful and just a beautiful thing to see with the community that's being built. And also we partnered with a church, a local church that's also a food pantry, and we offer hands-on culinary classes for free. And we teach them in like 5 different languages, and they're all like culturally relevant recipes that are submitted by the community. So it's some really fulfilling work. And also I just wanted to bring this up because at the heart of all of this work, really what we've done and what, our program continues to do is kind of like listening to what the need is and acting with care and ensuring that people's voices are heard, right? So with that in mind, I'm going to pass it on over to Heidi, and she's going to share a little bit with you guys about what we can do and what is like the first and most important step to some of this work. So, all right, Heidi, it's all yours.
Thanks, Kayla. If you don't mind, yeah, here we are. All right, I might be telling you to switch slide, but maybe you'll read my mind. We'll see how that goes.
So
So the question is, what do we do about it? And what is our position that's unique within healthcare? I want to tell you a story about our specific example at Providence. And this is really based in collaboration and vision and intention, and evaluation to see, did our best effort and the vision that we had in mind really produce the fruit that we had hoped? Where do we need to make changes? And what do our community members have to say about that? I think in thinking about any new project, ensuring that you have the people who are most affected by whatever change or idea that you have are centered as part of the conversation and have opportunities to provide feedback along the way is crucial to whatever you're doing. So the story of the Providence Community Teaching Kitchen really started with screening. And this is based in understanding the need. And in healthcare, we do something called the Community Health Needs Assessment every 3 years, where we bring together community members, key stakeholders, talking about what the needs are through focus groups, lots of surveying. And we identified in a community health needs assessment back in 2012 or so that one of the top needs in our community was food insecurity. So based on the survey and the understanding that we had about our community, we decided to put a plan together and move forward. And really then that took telling the story with our funders. So philanthropy and grants was a huge part of this story, as well as using data, identifying what the needs were and the plan to get there, and testing out some things, and then being able to report out on what we found. The effectiveness of storytelling, I can't emphasize enough. It's really how you get the message out and ensure that, again, your participants and your families and the people that are in your community are sharing the message that they feel like is most important. So next slide, please. So as a vital first step of anything that we're doing, we want to understand the need. That's where screening comes into play. We don't know what we don't know. And our first need here was to survey our own healthcare providers. And this, again, was based in collaboration. In Milwaukee, we're kind of unique in that we're just 7 miles outside of downtown Portland. And even though we're very close to the city, it can feel a bit like a rural community in some ways. And sometimes really cutting edge progressive things happen in small spaces, especially if you're a little bit off the beaten path or off the radar of other large institution driven decisions. So in Milwaukee, what we happen to have is connection with a family medicine residency program as our Providence health system. And so we decided, we know what the need is. Let's take a survey of our healthcare providers who will be most impacted by this change and find out, number one, is it feasible to address food insecurity in the clinic setting? Not only is it feasible, but is there a demand? So we develop a survey. We asked our healthcare providers if this is something that they determined would be feasible in that clinic setting. Ensure it was. We determined that yes, as long as we felt confident and competent in how to respond to the need, then our providers would be willing to go ahead and start screening. And so in the clinic, we developed and made use of the Hunger Vital Sign, the 2-part questionnaire, and started asking the question. And what we determined as part of that well child visit was that indeed there was a demand. We know that we needed to respond. Why is it important to even start asking the question? Well, you have to get a baseline of what you're working with and have informed data-driven decisions. And so by collecting the information and pairing that with not just screening to screen for the sake of understanding the need, but knowing our providers needed something to literally hand over to somebody if they were in need of a resource, having a plan, such as a list of hot meal sites or food banks or local organizations that were able to support food needs for our community members. We could print that off as part of the after visit summary and make it available in multiple languages. That was step number one. Number two, make sure that we had collaboration with a local partner so that not only would we just hand somebody a piece of paper, but we could also do a warm handoff to a local organization who happen to have the expertise in the area of multilingualism, multiculturalism, and adept understanding of how to respond for resource needs. So that is the intervene side, but we call it screen and intervene because they go together. I think as we know, by addressing food insecurity, we are much more likely when we meet the basic needs of our patients and at least understand how to access those resources that we are going to find meeting those clinical outcomes is much more effective. For example, addressing malnutrition, diabetes, hypertension, cardiovascular disease, depression, social isolation, all of these things have turned out to be positive, statistically significant, correlated outcomes when we are addressing the social needs of our patients. Not only do we meet clinical healthcare needs by screening and intervening, but we also find that our medical providers have an improved sense of well-being and satisfaction and purpose because all of a sudden the treatment that they're able to provide is that much more effective. They also feel supported. They know what to do. They know how to answer the question when they have the resources to share. And the other aspect of this is normalizing the commonality of the experience of facing food insecurity. Sometimes we're afraid to have the conversation because it's hard and it's difficult and it's uncomfortable. And really what we're doing is continuing to hide the problem. And when patients walk into the door and they know that they're in a trusted space where things like their basic needs that they were otherwise ashamed to bring up, but they're being asked the question as part of a regular intake and process. It might not feel comfortable the first time, but maybe the third or the fifth or the 10th time, we understand that this is a safe place to have that conversation and that somebody who is in charge of helping us with a treatment plan also understands that we can't possibly get to the treatment plan if we haven't addressed the basic needs. This is the importance of screen and intervene. So moving right along, specifically, I want to share the tools that we've been using. So as I mentioned, the first screening was of the providers. The second screening that we used was the two-part food insecurity screening tool. The third part is now a more robust social needs screener, which we call our social determinants of health screening tool. So where we started with 2 questions just for children, we moved along to address adult populations with those 2 questions, and then entire families at every single visit across 9 states in Providence Health. And now we know that you can't just ask about food and not expect that there are other issues happening. Let's ask about the other issues as well and know how to respond. There you'll find that we have 6 questions that we're asking. This questionnaire can be self-administered on a paper form when somebody's in the waiting room. It's also embedded in the electronic health record. So anytime you are going into a clinic and meeting with that medical assistant or that scheduling coordinator, this is part of the intake process. So what's great about having this embedded in the electronic health record, as you can imagine, we can pull data on what the results are. So we're documenting the screening, we're documenting the results. We're also able to generate referrals to our community-based partners who are following up with those patients within 1 to 3 days about how else we can support with the social needs. So we talk about this because data informs decisions. And when we have data that we can show, as an example, in 2023, across primary care clinics, we screened nearly 135,000 people for food insecurity and social needs. Of those people screened, that was about half that were eligible, 46%. So not even 100% who were eligible for screening. Things take time to implement, especially when they're new. And we're getting better and we have more data because of it. But on average, people were screened a little more than once a year. The guidance is to screen at least once a year for these needs. And of those who screened, of that 46% who screened, nearly 12,000 were in need of some support. And of those 12,000, 73% needed food. So food continues to be the top need for all the social needs that we're screening for across Oregon. That helps us understand how to respond. It also guides us in where we infuse resources. A couple of examples of what's come from this are pop up acute emergency food pantries embedded in clinics that also collaborate with nearby food pantries to help support the food provision and distribution, the volunteers that package food, and the referral process. So without this data, we wouldn't know where to go or what to do or who to partner with. The thing that you don't see here is that we also have data on the referral conversion. So for those who have screened and need support are then referred. And of course, like everywhere else, it's another database, but that's okay. We know how to pull a report from there as well. Eventually, those systems will talk to each other. But essentially, we can see how many people were actually connected and then able to engage in the follow through on a resource that was provided. If they did not get connected, why not? So all of that data is supported with this collaboration with a local nonprofit who's tracking the data and sharing collaboratively on the feedback so far. Next slide, please. So what are we doing at the Teaching Kitchen? You'll see that Kayla, as she mentioned, is busy working with patients in that beautiful photo. And that is one version of what we might be able to achieve when we address food insecurity. By screening, understanding the need, and engaging our philanthropy and grants, we decided we wanted to take it the next step further and not just hand somebody that piece of paper, not just connect them with a community resource, but have an on-site, in-person location where we could provide a wraparound, whole person centered model, no wrong door approach, so that somebody can come get access, a medical referral is what gets them into the door of the Teaching Kitchen. And there they'll be supported with one-on-one nutrition counseling, group medical nutrition therapy and cooking classes, diabetes education classes, an on-site food pantry, more recently expanded to a garden where we're running prescription gardening classes, as well as virtual opportunities, including a YouTube channel with on-demand content. Much to my children's dismay, like and subscribe on the YouTube channel. Find us there for more. But what you need to know, again, about our particular location is that we are on campus of a community-based hospital, which serves as a safety net hospital for the community. Small compared to others, and primarily serving our medically underserved population. At the Teaching Kitchen alone, the rate of food insecurity that our patients are facing is closer to 65%. And, you know, that is higher than average, but we also understand that the people who are accessing care are facing multiple chronic conditions and already struggling with things like transportation. And so it is behoove us to continue to be creative and wrapping our patients with that care that's needed. Next slide, please. So this didn't happen overnight. And this beautiful timeline is to show you that it started by screening and understanding that we needed to intervene with hands-on services such as nutritious food, hands-on cooking, opportunities to build community. When we were faced with a pandemic, we went virtual. We were able to leverage our surgical services videography team, who also had time on their hands. And by the way, Jocelyn didn't tell you this, but it was Jocelyn and Kayla who launched the virtual programming and got us, you know, able to engage our patients during a time that otherwise was faced with depression and social isolation and uncertainty. And we were able to maintain the same level of engagement virtually that we had in person. Since that time, we've been able to bring in-person programming back. We've also expanded to the garden, and the program is expanding with things like road shows and community partnerships and culinary medicine for employee wellness for external employers, and, you know, integration of teaching kitchens and medical education. So, you know, we are growing just as the demand and national attention to the food as medicine movement is growing. But let's not forget that the reason that we started in the first place was due to, you know, the deep social need and repairing the damage that's been done over generations. There are consistent themes that our patients are facing, and just the tip of the iceberg is hunger. So the more we can get out into the community, the more we can address the underlying issues through the programs like being in the garden and growing fresh vegetables and enjoying food together, the better we're going to become. With that, I'm going to go ahead and pass it back over to Kayla to talk more about how food insecurity is presenting in the clinic.
Thanks, Heidi. All right, so I'm going to go ahead and put my provider hat on real quick. And I just also have to say, even if you're not working in the medical field, you're not working with patients, I think still being able to understand how food insecurity might present amongst individuals is very, very important. So just keeping in mind, food insecurity affects the whole person. That's physically, mentally, and socially. So the first part I wanted to cover is just what are the food specific impacts? Typically, when we are, unable to access consistent food, a lot of times we're going to have limited nutrition. So what that might mean is we might be missing out on key nutrients. Maybe we're seeing more nutritional deficiencies show up in our lab work. Maybe you might be talking with somebody, or maybe you're a caregiver and they tend to say that they eat the same few items regularly. So there's not very much variety. Or even just hearing like, hey, I'm skipping meals altogether. That could be an impact of food insecurity. I also see unhealthy eating patterns quite often. So this could be binge eating behaviors when food is available. It could also be or maybe still feeling hungry after eating. These are all very common in folks that are facing food insecurity. I also want to mention that a lot of these unhealthy eating patterns tend to kind of continue long term. So say there's an individual, or maybe you yourself have faced food insecurity. If you develop some of these behaviors like binging or unable to listen to what our internal body cues are telling us, or maybe you suppress your hunger cues quite often, this can actually carry on long term, even when we have sufficient access to healthy and nutritious foods. So there really is that long term impact that we might see in some of these behaviors around our eating pattern and just food in general. So some non-specific food impacts, though these are impacts that go far beyond food, are going to be things like physical symptoms. This could be fatigue, weakness, dizziness, maybe a loss in weight could often be related to food insecurity. Also worsening health. So maybe we experience chronic pain, or we have chronic conditions, and these conditions get worse over time, right? This could be related to food insecurity or inadequate nutrition intake. This also often can lead to more frequent ER visits or hospital stays. And then lastly, I want to mention mental health struggles. So that constant worry of, when is my next meal going to come? Do I have enough resources to get through to the end of the month? Am I able to consume a diet that's going to fit my dietary needs? I'm working with a dietitian, I'm working with my provider, but I just don't have the resources available. This continued stress can contribute to things like anxiety, depression, and just high stress within the home. So again, I think as providers or caregivers or just working within the community, it's important for us to recognize these signs, and then we can intervene and offer that support, what Heidi was just discussing. So as a dietitian, there are some nutritional considerations that I like to highlight when I'm working with this age group. And I just want to mention that a lot of times these recommendations can often be difficult to meet when folks are facing food insecurity. It can become very challenging. The first one is going to be protein intake. So typically for anyone over the age of 55, your protein needs significantly increase, typically to around 1.2 to 1.5 grams per kilogram. And the reason why our protein intake increases is because we want to sustain or maintain our lean body mass. Our lean body mass is very, very important as we get older, because as we naturally age, we lose muscle mass. And that term is called sarcopenia, right? But sarcopenia can actually be made worse, or usually it's made worse when we're not able to consume high quality or enough protein from our diet. And when we're facing food insecurity or we have limited resources, a lot of times, foods that are high in protein, or at least high quality protein, like meats, eggs, fish, legume, tends to be higher in cost, right? Something that we're going through right now at the teaching kitchen is we're being asked to make some cuts here and there. And the main food food products that we've had to kind of scale back on from purchasing are our animal proteins, because they are the most expensive by far, right? Other pieces are going to be things like appetite changes, changes in taste. This is actually normal as we get older, but it makes it really difficult for us to meet our nutritional needs. And then when we're faced with unstable food, it becomes even more challenging. Nutrient deficiencies are also something else that we see often in food insecurity, but also as we get older. So there's key nutrients like vitamin D, B12, calcium, and zinc. These are all essential for our health. Intake needs also increase during this time. And if we're not able to meet our needs, then this can lead to deficiencies. This can affect our bone loss. It can affect our cognitive ability, and it can also affect our immunity, so weakened immune system. When we are experiencing physical limitations or cognitive decline, often this makes grocery shopping more difficult, meal preparation more difficult. And when we don't have that additional support on hand, typically what we're going to do is we're going to choose foods that might be less nourishing, things that are really easy to prepare. So that could be, maybe just taking a TV dinner and put it into the microwave, right? Because it's easy and that's what we have access to. Those are the resources that we have. It could also lead to just skipping meals altogether, right? So we have to consider that for older adults facing food insecurity, that these challenges are even more pronounced. And it's really, really crucial for us to be able to identify them and address them to make sure that folks are meeting their nutritional needs during this time in their life. Okay, so let's talk about our culinary medicine classes. I see that there was a couple folks in the chat that had some more questions about our classes. So this is really what makes the Teaching Kitchen unique, or makes our program unique in comparison to other nutrition programs, is because we offer culinary medicine classes. And I do have to say that this is probably my most favorite part of my job and the community that we've built here. But Teaching Kitchens are really those learning labs for life skills. So it doesn't matter if maybe you have absolutely no nutrition knowledge, maybe you are a seasoned cook, maybe you're just going through a new walk in life, right? I hear from a lot of patients like, hey, I'm really struggling with, being able to follow some of these dietary recommendations that we're talking about because, I'm not used to just cooking for myself. I'm not used to just cooking for one or two people because for so long I cooked for 7 or 8, right? So being able to like scale back on recipes, there's just a lot of different avenues that folks can kind of be referred to a class and get so much benefit. I think as a dietitian, I'm also very privileged to be able to refer patients into these classes when they share with me that they're struggling with not only cooking, but possibly, forming connections, or they're feeling socially isolated, or they don't have the support at home that they feel that they need to be successful. So I'm able to, plug them into a class and they can kind of learn a little bit more about healthy eating. So the cool thing about our classes, all of the patients that come through our doors are going to be screened with the screening system that Heidi just spoke about. Many patients who take our classes not only take our class once, but they'll continue to follow and engage in our program long term. So at the beginning of every class, we will screen a patient and then we'll come up and we'll screen them again, maybe in another like 4 to 6 weeks, right? When a new series starts. And I think that's really important because like I mentioned before, is that really any life event can change your status. And so we're able to kind of flag that and offer the resources and the support that folks might need. Folks that are accessing our family market, they are able to do bi-weekly visits to receive a food box. So typically patients will come early or they'll stay a little bit later to put together a food box, and they'll typically do that every other week. We also provide take-home recipe bags. So the recipes that we prepare in class, we cook hands-on all together. They get to eat, we all get to eat together and try the recipe, but then they take those ingredients home and they get to practice, or they can at least use those ingredients for something completely different. Our kitchen also offers adapted kitchen tools and utensils. We are also an ADA compliant facility and kitchen space, and we are offering classes in English and Spanish. But what I really wanted to highlight is a class that's very special, and we've been teaching this series for, I would say, probably the last year and a half, I believe. And it's called Stone Soup. It's our healthy aging class. And the reason why this series is so special is because it was actually created by one of our volunteers. Her name is Charlotte. She's here in this picture. But Charlotte was actually instrumental in opening the teaching kitchen and getting the teaching kitchen started when she was a case manager in RN back in 2014. So she's since retired, and she's come back to the kitchen as a volunteer, and she's collaborated with me and the other dietitians of creating this really cool 4-week series that highlights nutrition education, but it also kind of pinpoints the importance of social connection and combating that social isolation piece. So I don't know if any of you guys have heard of the story of Stone Soup. I hadn't until Charlotte had brought it up to me. So I'm going to share the story with you guys, just because it really highlights the foundation of why this series was created. So apparently there was I would say a traveler, and he was traveling to a new village that he had never been to before. And so he had posted up camp and, was kind of seeking food, and no one wanted to share their resources with him. Like, no one wanted to share their food. They're like, no, you can get your own food, blah, 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 blah. So he set up camp, started a fire. He hung up his pot, filled it with water, added a stone. And then he kept telling everybody, like, oh, this is going to be the most delicious soup. This is going to be so amazing. It's going to taste so good. And so as the villagers were like walking by, they started to get curious, right? So then they would add like an onion and maybe a carrot, some celery and potatoes. So they just kept adding all of these like delicious foods that they had on hand. And by the end, when the soup was basically all ready, it was a nutritious, hearty, delicious soup. And the traveler shared it with everybody, right? Because everyone collaborated. And what that showed was that by everyone pooling their resources together and working together, they created something that was so delicious, so nutritious, that they wouldn't have been able to do individually. So that's kind of the idea behind this course, is like taking a look at connection, collaboration, sharing our resources in the time that everyone's able to spend together. And Charlotte kind of is going through this path and journey of life herself. And so it's so amazing to hear from her and her experiences, and having her to be able to support our patients in a way that not all of us can. So it's a really cool course, and we can talk a little bit about that maybe during the Q&A if you guys have more questions about that. But I'm going to go ahead and pass it on over to Heidi, and she's going to talk a little bit more about creative solutions in regards to our program. So here you go, Heidi.
Thanks, Kayla. Trying not to cry. Here are just a couple examples of additional creative solutions that we've discovered and come into. On the right is a Healthy Aging Summit that's coming up in the Seattle area. And this is going to be put on by some collaborators of ours at Swedish Providence, who also have gotten consultation around starting a teaching kitchen. Meanwhile, working on brain health, have discovered this, the value of putting together community-based, service-oriented, wellness-focused opportunities for the community to come together. Our team went up and visited a couple of years ago during the first one. This will be the second one. So just another way of thinking about addressing wellness in the community. You could easily include some hands-on cooking at one of these sorts of service-oriented events. On the left, you'll find a photo here. And this started as a project last year. Again, building on that health equity grant, we wanted to expand the model partnership that we have with our local nonprofit Growing Gardens, and respond to the call of our own employees at that location who had been volunteering their time to support a small urban garden that is nestled between hospital buildings in downtown Portland area. And they said, hey, we can't do this alone anymore. How did you do it? And so we said, let's partner with Growing Gardens. Let's go ahead and build this out and leverage this as a space to identify and address food insecurity needs and wellness concerns for our own staff members. Lo and behold, what developed is this beautiful space that we call a sacred space, the Garden of Hope. And It's being used by, in this particular example, the Providence Acute Care Rehab Center. And with that, we're going to show you a brief video from a patient who has been impacted by the space.
I'm relearning walking, and so I lost my center of gravity. I'm having to retrain my brain to know where my center is.
She loves gardening, and so she had like that sparkle in her eye about it. We were working a lot on her standing balance.
One more sunflower? Yeah, we gotta find the perfect one.
For her in particular, being able to stand out there with her walker and do something that she likes to do, she was able to maintain her balance better.
Cute little ones.
If you look at it from a neuro point of view, if you enjoy gardening and you want to do those things, you're going to have more connection in your brain and get better more quickly.
Oh, it has helped my confidence quite a bit. Yes, and there are some other patients in there who enjoy, handling the flowers, but aren't ready yet to like come out to the garden.
And then we're able to bring the flowers up and create these little bouquets. These plants started from a seed. And so when you look at the symbolism with sometimes our patients here when they start from nothing and then it turns into this, it's like, you're like, wow, like you did all this rehab and now you went back home and you are able to get back to your life, and it's amazing.
It's life out here. It's just existence inside. Life is outside.
Thanks, Kayla. Now I'm really crying. But like Lauren said,
No.
life is outside. It's just existence inside. So I don't know how many of you are ready to get outside after this, but no, just kidding. I think, what was intended to be, this leveraging this space and making it beautiful has turned into the heart of what we had hoped for in terms of integration, gardening in a healthcare setting in ways that we had no idea would result. And so, trying something new and collaborating and seeing what happens and then telling a story about the result, I think is phenomenal. And I think next up from, based on this story and this experience that we've had, we now have the food and nutrition services team interested in growing flowers so that they could include cut flowers on patient dining trays in hospital rooms. And another one, as we're thinking about sustainability, is trying to get creative around how do you sustain something like a garden for a hospital system? Well, exploring billing, can we license the space to be a billable place where those rehab nurses and or dietitians or physical therapists or doctors can just meet their patients in the garden for a group visit, for example. So getting creative, sometimes we create amazing things based on grants and then we need to figure out how we sustain. And that's where that collaboration and vision and intention and ultimately evaluating and getting feedback from those who are engaged will help determine next steps. Finally, here are some resources and just some ideas about how to make a difference. I know many that are on the webinar today are already engaged in a lot of really cool collaborative opportunities. I saw some really great stuff happening in the chat around new opportunities to collaborate. So if you don't already know about these resources, I would encourage you to check them out. And finally, if you have a lot of spare time on your hands and you'd like to read more about some clinical outcomes that we've discovered or some highlights around teaching kitchen work, I would encourage you to check out some of these links. And with that, thank you for your time and your interest and your dedication to achieving, a healthier communities together. And we do want to open it up for some questions or comments that you might have. Thank you.
Okay, I wrote down a couple questions from the chat, but before we get into that, I have to say, can you guys, those articles are long and amazing. Can you share this? This just really brings a lot of pride to me. Can you share what happened when you integrated culinary medicine diabetes classes, the culinary medicine piece in with diabetes classes? What was the result of that combination?
More fun. Oh,
Yeah,
I mean,
woo!
yes, fun, enjoyment, but also statistically significant improvement in A1C over time. So we know that, diabetes education adds statistical significance compared to zero. But if you add a culinary component, then you've now increased your clinical outcomes exponentially. You've also built community. You're enjoying the education a little more. We have quotes from our participants saying, you made that topic really fun, which, can be hard to do sometimes.
I just bring that up because I got to be a part of that and I loved that program so much. And I just want to say, they've really Heidi and Kayla have highlighted here the importance of having a food pharmacy, how the classes make an impact and help with social isolation. And I just want to tell a short story that really exemplifies the importance of this social connection for people. I was working with a patient for quite a long time, trying to just help him get his diabetes medication regimen together. It was just a kind of a hot mess. We had tried to set timers. We tried to do this and that to help him remember his insulin regimen. He came to one of our diabetes classes with the nutrition piece, and we're cooking together. He's getting to interact with people he's never met before. Weeks later, he comes into an individual appointment we had, and he was able to get his medication regimen on track because he had met with another participant in the class, and they talked about strategies that patient uses. And to me, this just really spoke to I could have all the clinical knowledge in the world, but when it came down to it, this person needed somebody else who was in the same shoes as him to say, hey, this is how you could actually do this and make it work. And I loved being a part of this. And so I just felt like I needed to tell that story. Okay, let me draw it back here though. We had a couple questions in the chat. So Amy was talking about in the chat that her institution is interested in starting a community teaching kitchen. Do you have one or two recommendations that you would give for somebody who's putting their foot in the door, wanting to get started with this?
Yeah, the first one is check out the Teaching Kitchen Collaborative, and they have a lot of great resources for startup toolkits. Whether you're looking at, how to do this as a facility or, what kind of clinical evidence-based practices you should consider. So check out Teaching Kitchen Collaborative. Another one would be identify who else around you is already doing this work. And you don't need a fancy built-in model teaching kitchen version. It could be a church pantry, it could be a local neighborhood school. I mean, there are kitchens that exist. So consider your resources and your collaborators as you're going into this.
Awesome. And I'll say too, you guys briefly mentioned the Community Teaching Kitchen Roadshow. And, I got to be a small part in that as well, but it made a huge impact having something as small as a bag of spatulas and a portable griddle. You can go to any place that you want and teach how to cook a recipe. And it's as simple as that for getting started with a teaching kitchen. So yeah, know your collaborators, look at what's already going on, and get yourself a bag of spatulas. Okay. I'm just kidding. Lorena had some really great comments in the chat here talking about some of the challenges with food insecurity in the older adult population. And I just wanted to ask one real specific one that she had. She had mentioned that sometimes food pantries just don't have the foods that people need for their specific diets or nutrition plans they need. And we know that, right? We've gone to food pantries before. We were like, whoa, these foods are not appropriate for someone trying to manage their blood sugars. So let me ask you guys, how have you tried to address some of the challenges patients face when it comes to needing specific foods or nutrition plans?
Yeah, I think that's a great question. I feel like it's just taking a look at what is available, right? Like a lot of food pantries are going to have things like dried grains or canned beans, right? Like just plain canned beans. It might be in a can, but that's okay. You know, we could still utilize that as a resource. I think the biggest piece of things is trying to find that support where maybe it's working with a dietitian or somebody else that can help guide a visit through a food pantry so folks have a little bit more knowledge behind which foods to choose because it's really confusing. And I think that's also the biggest challenge because you have so many options that are kind of just there, especially a lot of maybe less nourishing options. So if you can get a little bit more knowledge behind you and try to figure out what we can actually pull together, kind of like that picture I just sent you, or I shared with all of you of my patient in his food pantry, and he was just taking a look and he was like, I have absolutely nothing, right? But you know, trying to put some things together and figure it out. But it's really hard. And then tapping into different resources. Like I have so many patients who go to like 3 or 4 different places because they know they can depend on, you know, their meats from this place. Maybe they can get fresh produce or canned goods from this place, and they kind of just bounce around and use different resources, which I know is also a huge challenge in itself. I know, Heidi, did you have some other things to add to that?
Go find a garden.
Oh.
I think there might be some on this call who are familiar with community garden work and maybe would share some vegetables.
Yeah, like growing your own. And I think there's so much more that goes into, or so much more benefit that goes into growing your own food as well. There's like, I don't know, feeds the soul in a different way. It's a great learning opportunity, but yeah, it's cool.
Yeah. And I also just want to highlight one of the unique features of the teaching kitchen that makes you guys extra special up there is the partnerships that you've gathered over the years and your location. I know when I worked up there, you guys had Bob's Red Mill, who was able to donate certain grains and some other strategic partnerships that when patients did come in with something like, they need a gluten-free diet, we were able to take them back through the pantry and say, hey, look, these are the items that are gluten-free. This is how you cook with them. And we know that gluten-free items, first of all, aren't always available when you go to a food pantry or extremely expensive at the supermarket. So there was just some really unique things about being in that environment that you guys have up there. I also just wanted to mention as a clinician, I've worked in a lot of different clinical environments, and working at Providence was really different because of that social determinant of health screening. When you have that screening in place, and then on the backside, you have a place to send patients, it really boosts your confidence level in asking those really tough questions.
Yeah.
It's so hard to ask somebody, hey, what's going on with your transportation? Are you food insecure? Do you feel safe in your home? Do you have stable housing? Because if someone says yes to that and you don't have the resources, you feel so lost. So it was incredible to work in a system that says, okay, if you have this going on, here's what we can do about it. Go over and talk to Kayla and Heidi at the teaching kitchen, and they will literally hold your hand and walk you through that pantry to get you the foods that you need. So
Yeah.
I just also wanted to speak to the unique model that Providence has. It's not always available everywhere, but is wonderful. But should be. Okay.
I know.
Okay, and enough of me just missing you guys up there. Does anybody else have any other questions for our panelists? I'm just looking through the chat here. Okay, so what I want to say is I really want to thank our panelists. I appreciate you guys for being here today. I sent out the link to the Community Teaching Kitchen's YouTube page. If you are interested, scroll to the bottom and look at the patient impact stories. There's a story there from Candy and one from Marlene, who are patients from the Teaching Kitchen. Grab your box of tissues. They're gorgeous videos, and they really speak to the work being done up there. After our meeting today, I will also, once this video is recorded and edited, I will send this video out to all of you. It will be available on our SEAL website as well. Is it okay for me to share your contact information as well? I will also send Heidi and Kayla's information out if you'd like to connect with them. Next month, we have another very exciting webinar coming up. Our MSW intern that works, our Master Social Work intern Claire Grimes will be presenting about ageism in higher education and ways we can combat that. So we really encourage you to join us for that. And then in June, we have a very special edition of the webinar that will have two very special panelists who are going to be talking about caregiving for the LGBT community and the challenges and successes that have been happening with that. So very exciting webinars coming up. If you're hearing these topics or you saw theirs and you're like, whoa, I have a really great idea about something I want to present about, reach out to me. Our goal at SEAL is to uplift anything going on in the field of aging and longevity from researchers, from students, from professionals. So please let me know if you have an idea. I'm here to support it. All right. Thank you all for being here, and we'll hopefully see you next month.
Thanks,
Thank
guys.
you.